This fall, Nan is heading to Palm Springs, California. Set against the backdrop of desert skies, we're creating a space for neonatal nurses to take the stage, sharing knowledge, amplifying voices, and driving change. Join us from September 9th through the 12th, 2025, to learn from experts, engage in powerful discussions, and take action to drive meaningful change in neonatal care. Registration opens April 24th, so mark your calendars now to take advantage of best value pricing. Head to nan.org/conference to learn more. Hello, and welcome to NANcast. I'm Jill, your host. Research, evidence-based practice, and quality improvement. We all know these initiatives are essential for advancing neonatal care, but let's be honest. Many NICU nurses and APRNs feel like research can be very intimidating. We all have those curious questions, but maybe don't know where to start, or it feels too complex and time-consuming. How can I, as a bedside nurse or APRN, take the first step in research, EBP, or QI without feeling overwhelmed? Today's episode is all about breaking those barriers and showing you that research, EBP, and QI are more accessible than you think. To bring this to life, we have special guest Sarah Yingling, a NICU bedside nurse who took the leap and started a quality improvement initiative in her own unit. Sarah will walk us through her step-by-step process, and she's joined by her mentor, Dr. Elizabeth Schierholz, an NNP and nurse scientist who helped guide her along the way. Together, they'll break it down into practical, actionable steps so that you can feel confident about getting involved in similar projects in your unit. Whether you're a seasoned nurse looking to broaden your influence or a new grad wondering how to get started, this episode is packed with practical tips, stories, and encouragement to help you take that next step. Let's get right into it. Research, evidence-based practice, and quality improvement can often feel intimidating to the bedside nurse. But today we're going to break those barriers down and show how accessible and impactful these initiatives can be to our patients. So, Elizabeth, you have been an incredible mentor in this space, helping nurses how they turn their ideas of what we can improve into reality. To kick things off, can you help us understand the difference between research, evidence-based practice, and quality improvement?
I would love to. I agree that sometimes these terms can be used and interchangeably in the space of talking about scholarly work in the NICU, in any kind of healthcare setting, and definitely the amount of knowledge we have of those coming from nursing school to the bedside, the clinical environment does not set us up for understanding sometimes the difference, and yet we hear that all of these things may or may not be happening around us or be used to inform our practice, to change what we're doing, or that there might be ongoing work in these areas. So when I think about trying to understand, I'll definitely go through some academic definitions, but before that, I think that it's helpful to just think about what the intention of what we're doing is. And so when we think about research, we want to be able to generate new knowledge. So if we have a topic and we don't know something, and so about a particular thing. So do neonates experience pain? If we ask that question and we go to a source of literature, we'll actually find out that we know a lot about pain in neonates. And so therefore, we wouldn't necessarily want to do research on that topic because we can very easily query and see that we actually know a lot about pain in neonates. And so when it comes to pain in neonates, we don't want to generate any new knowledge per se. We want to actually maybe just improve what's happening in our NICU regarding pain. And so the next level of question is then, are we following what the evidence says? So when we look at all these articles, are we actually applying them in our practice? And if the answer is no, then this gives us an opportunity to apply evidence-based knowledge into practice, which is how we define evidence-based practice and implementation. Sometimes what we find is that there is practice of trying to provide good pain management or acknowledgement of pain for neonates in our environment, but we don't do it consistently, or and the way that physicians approach it, nurses approach it, nurse practitioners and other providers in the NICU, sometimes all do it differently. And so we find that there's really inconsistency either in what we're using to help with pain for neonates, or how we're measuring it in the infants. And so this would be quality improvement, where we are trying to do a better job of improving an existing process, knowing we already acknowledge there's pain. We already acknowledge that there's interventions to treat pain, but we don't do it in a way that all of the infants in the unit consistently receive the same care. And so that's how we define quality improvement work, and how it differs from evidence-based practice, which means we're not currently doing a practice that evidence says is helpful for our patients, and then research which says we don't even know about this topic within our unit, and so we actually need to go and explore and learn more about that. So that's my way of distinguishing those three topics.
That was such a great breakdown of the different types of research, evidence-based practice, and QI. But how would a bedside nurse or an APRN apply that in their NICU using the definitions that you gave us?
Yeah, so I think that it starts with having an idea or a question at the bedside. I think about something that I'm observing in my practice on a daily basis. And it might be that I just have a question like, is this the best way to insert an NG tube? Is this the best way to give antibiotics? Are there other options? And so either that, or sometimes there's a problem that I identify. I feel like we don't capture our knowledge about a specific area, or I see that we, over time, keep forgetting something or something doesn't get done. And so I'm thinking that there's a problem with how we're doing things. And so then thinking about, one, we need to figure out like what of those methods would help us get the answer. And so that's when we go back to like, what is our goal in me asking this question or having this inquiry? Do I want to fix something? Do I want to improve something? Do I want to just have more knowledge about it? Do I want to share that knowledge? And how am I going to know if whatever I seek to do, how am I going to accomplish that? And so those are kind of the pieces that I encourage anyone to think about as they're starting, before you're digging into the literature, before you're even trying to define like what of these different methods do I need to use? Because really, truly, like the best questions and the best work for all of these topics, whether it's quality improvement, research, or evidence-based practice, comes from somebody at the bedside really identifying a problem, or potentially having just a question out of curiosity. And so we see that these questions often come from, sometimes it's a near miss, and sometimes it's because we feel terrible that something happened and somebody's asking us about it, and we're like, yeah, I wish that didn't happen. How do we make sure that doesn't happen again? Sometimes it comes from a regulatory agency pointing out that we have inconsistency in our practice. And so that gives us an opportunity, usually to do process or quality improvement. Another way that we sometimes get an idea is from our nursing quality metrics. And then a lot of times it comes from a family member at the bedside asking us a question about why we do something, or is there another option of delivering a medication or a treatment or an intervention. And so all of these are places for us to start to have that question at the bedside that piques our interest, and then just developing, kind of play it out in your mind, like again asking those questions. What do I want to accomplish by digging into this topic? What am I hoping to achieve, and is it possible to figure out what that is? And then from there we can start to then apply that methodology, and figure out the methods, like I mentioned earlier, of what's the intention of, do I need new knowledge? Am I trying to then go to the literature and say, there are some ways of improving this, we just need to bring them into our unit? Or we do this inconsistently, and so let's do this more consistently. The next kind of step is to say, is there enough current evidence to answer the question or to fix the problem? And if the answer is no, then this leads us into the bucket of research. But if the answer is yes, then we have two options. One, evidence-based practice, where we apply the evidence into our units and improve. And then, again, like if I said earlier, if it's already being applied but inconsistently, then I look at quality improvement and process improvement processes. So what are all of these the definitions of all of these terms? So research is the systematic investigation, including development, testing, and evaluation, designed to develop and contribute to generalizable knowledge. So the knowledge that we gain, we want it to be able to apply to either every team in every NICU, or every baby in every NICU, or every family in every NICU. We don't want to find something new that is just unique to a small group of patients in one unit. So we want to think a little bit more broadly. Research drives the other methods that we're going to talk about today, though. So research is what informs evidence-based practice, quality improvement, and process improvement. We use that evidence that is generated in order to change those other processes and improvement work. When we talk about evidence-based practice, we're talking about a process of inquiry and a way of providing quality patient care. Evidence-based practice uses a problem-solving approach to a clinical practice that integrates the best research with clinical expertise and patient preferences and values to facilitate clinical decision-making. And so taking what has already been studied says there is evidence to support a practice, and then how do we implement in this specific clinical setting? And so unlike research, evidence-based practice is specific to a clinical population or a clinical unit in order for it to be best adopted and implemented in that space or for that population. And the steps of evidence-based practice still start with a question. Ask the clinical question, collect the most relevant and best practice, and then critically appraise the evidence so that you have the best evidence for your unit or your population. And then integrating that evidence with the expertise of the team locally, and also not forgetting about the patient preference and the values of the patient population, whether that both be the infant and the family in the NICU, in order to inform practice change. And then evaluating the impact of that integration and adoption of that practice is the last step in evidence-based practice. We want to be able to measure that what we're doing is effective in achieving our goal. One of the common models used for evidence-based practice is the Iowa model. There's also some other models, but the model behind evidence-based practice is designed to have a framework to help achieve that practice change and that improved quality of care. Quality improvement and process improvement are where sometimes we get confused the most between evidence-based practice and these methodologies. And again, I'll just repeat myself, but evidence-based practice really stems from, we don't currently have this practice in our setting, but there is evidence to support it. And so we're bringing something new into our clinical environments in order to implement it to achieve those better outcomes. Like I used an example of pain, and I'll use that again for quality or process improvement. We won't find that there are many NICUs that don't have any idea of any kind of practice for treating or for even tracking pain, right? We know that that's actually a regulatory standard, is that we track pain, but we don't often do it consistently. And so one of the units that I worked on a project to say, let's actually make sure that we use one scale for measuring pain for our surgical patients, so that we're using the same scale and that we're treating pain at the same level rather than treating it based off of some subjective provider and communication, at the bedside. And then let's treat different levels of pain standardly. So I'll just use an example. If the pain level is 4, let's treat that standardly for all babies, rather than when I come to the bedside, I use a certain treatment for a pain level of 4, and the next person uses a different level of treatment and maybe even a different agent for that same level. So that would be quality improvement, where we acknowledge that we already treat pain, but depending on the level of pain and the provider, there's a lot of variation in practice. And so we're not doing it consistently. That's quality improvement. We want to make sure that we are noticing that there's inconsistency in our practice. Again, we go to the evidence to find out what are the standards and does the evidence say about providing best practice, and it's used to standardize or to provide more consistency. And when we think about quality improvement versus process improvement, generally what we're talking about in quality improvement is that we are measuring outcomes to the patient. So the example of pain that I use definitely has something we can measure to make sure that we are more consistently treating pain in our patients. If we wanted to improve the efficiency of the medication getting from the pharmacy to the bedside in order to treat pain, that's when we talk about process improvement. Process improvement generally involves some kind of efficiency, and so we want to make sure that another example is in improving the golden hour process. Eventually, our ultimate goal is quality improvement. We want to improve that the baby is getting the best treatment in that first hour of life. But one of the processes for that is getting an x-ray to the bedside to confirm whether it's the ET tube or the UAC and the UVC before we use them, if that's part of our process. And a lot of times there's delays in getting radiology to the bedside. And so a process improvement project would coordinate with the radiology department in order to more efficiently get our radiology techs to the bedside, and then we track that by time. From the time we notified them till they came to the bedside, were we efficient and improve that process? Same with pain medication, right? If we notice pain, but it takes 20 minutes to get the pain medication from the pharmacist or from the Pyxis because of delays, can we improve that process in order to then improve the quality of care that we're giving? One of the common models for quality improvement comes from the methodology from the Institute for Healthcare, the IHI, and uses PDSA cycles: plan, do, study, and act, and repeating that in very small cycles in order to achieve practice change and work out the variation of care and work out what the process is in order for it to improve. So those are some of the more in-depth definitions that help us understand how to take an idea at the bedside, use the terminologies in order to accomplish what we're doing in order to improve care.
I don't think that any nurse has a lack of questions out there about why are we doing something this way? We can improve this. But with all of those explanations, I think it sets a really good groundwork for nurses out there to say, oh, wait, I can use that question and I can apply these types of research in my unit. But we actually have someone with us, Sarah, who brought this whole process to life in her unit. And she took that leap and made research not scary and started a quality improvement initiative in her unit. Sarah, can you share with us a little bit of your journey in the NICU and what first sparked your interest in quality improvement and research in your unit?
So I have been in the NICU for 2.5 years. So I am still a baby nurse here. So very much was a little intimidated with this whole quality improvement, big project sort of thing when we started. But I was sitting next to my, unbeknownst at the time, project partner on a shift, and her and I were just discussing some of our frustrations with our current care models for certain babies, specifically our small baby population, so any baby that's under 32 weeks, and how we have some lack of standardization. And so we were both we came from different hospitals that had different processes and different bundles in place and different cares. So we were what can we do to get this to our hospital? So Caitlin was like, well, little do you know, I'm currently chatting with our leadership about a like IVH bundle. And I'm like, oh, great. I love that. Can I get in on that with you? And she's like, of course. I need somebody to help with this anyway, because it's a very large project. And she had a meeting, and then she comes back to me and she goes, so we're actually going to be doing a whole quality improvement project with the Vermont Oxford Network. And I said, okay, cool, great. I have no idea what that means, but sure. Definitely at that time I was working straight night shift. So that was a little bit of a struggle too, of being like, okay, can I still do this? I'm working straight nights. How can I help with this? And so we sat down with our leadership team and our mentorship team, and we were like, we don't know what we're doing. We know what we want to do. We know what we want to fix. Help us figure out how we get there. Because my project partner nor I have like a master's degree or postdoctorate or any of that sort of thing. So we are like the last sort of any type of quality improvement or that kind of project. We last talked about that in nursing school. So we're like, we don't know what we don't know. And so that's kind of how I got started, was just with a thought and a conversation with a fellow bedside nurse of being like, we can make this better for the patients. How do we go about that?
I love the fact that it started with a question, and absolutely as a night shift nurse, you can be involved in anything. I have been a night shift nurse pretty much my whole career, so I have a strong feeling for night shift, and I think that a lot of times people think that they're not involved because it's not during that natural operations of the hospital, but it can be done. So I think that should get out of everybody's head. So it started with a question, and you guys went to your leadership to talk about this. What other stakeholders did you have to bring in to get this project rolling?
Yeah, that's a great question. So our project has quite a bit of stakeholders. We have obviously my project partner and I. Then we have our nursing leadership, so like our associate clinical managers and our clinical managers. And then we have clinical practice specialists who write policy, and our quality improvement is a big part of their job. And then Elizabeth, who's on this podcast right now, she is our lovely nurse practitioner and also big into quality improvement and nurse scientist. So she is a big stakeholder in that as well. We also went and sat down. Our unit has a quality improvement like leadership meeting. We sat down and presented to that, and that team includes the clinical practice specialist, associate clinical managers, respiratory therapists, nurse practitioners, fellows, attendings, anybody that works in the NICU pretty much in any sort of leadership capacity is on that. And so we really got to talk to them about the project and got their buy-in.
So it's not something that you do alone. It wasn't just you and Caitlin trying to take this on yourself. You had Elizabeth as your mentor, and then other resources that you have to use. So I think that's important to know that this is not something that can be done by yourself, that you need to have resources.
Sarah's really fortunate to work in a unit that has a lot of structure in place to help support projects like this, and definitely the unit joining the Vermont Oxford Network's current quality collaborative really helps to provide some of the structure that is necessary in order for projects like this to be successful. But I don't want that to be discouraging to people, because like you heard from Sarah, all of our units have physicians, respiratory therapists, nurse practitioners, or other providers and nurses, both days and nights, that are involved in the work of taking care of our infants. And so one of the things that you can do if you don't have those structures in place and you don't have a project partner who's already kind of like paved the road a little bit to get you started, is that you can take that idea, just like Sarah described. She was sitting at work, she felt like something needed to be done. And so if we go back to that just initial question, I want to improve care, and she's going to tell us a little bit more, but I'm going to give you a sneak peek in that, really thinking about, are we providing the best developmental or neuroprotective environment for our small babies? And so what does that mean? And so before you necessarily gather all of the people that you need to know, we can go back to that question about neonates and pain, and we can say, what do we know about the environment that small babies are taken care of? What is helpful for them to decrease the bad things as far as development and neurocognitive? We don't think quite about cognitive when they're so small, but yet what are the things that we're doing when they are small that are going to affect their cognition and their development later on? Do we know anything about that? Again, that's research, and there's research that has been done. So based off that research, what do we know that actually is best practices? And so finding out just in your unit, is there anybody who specializes in this, who knows a little bit more, or do you become that spokesperson for your unit? And that can start with something that you can do, because the initial steps of research and quality improvement and evidence-based practice start with that question of what do we know and what makes sense for our unit, and then starting to gather a team of who would be stakeholders to join you in this practice. One of the things that's really, really important when we're working on any of these methods to generate knowledge, to improve clinical practice, is to actually be able to quantify what is happening. And sometimes the quantification can be part of the challenge. And so this is an area where thinking about what are you observing that is leading you to believe that something could be done better, and then thinking about what that is. So one thing, we don't know exactly how light and sound affect our babies later on. Not something necessarily that we can measure the effects of that, except for the fact that we're talking about, if we turn bright lights on, do our babies seem to have more events during that time? If it's noisy, do we notice that there are times where their saturations are lower? And so observing these types of things and then linking that to the evidence that you go and search out, what do we know about light and sound? Thinking about two environmental factors that we actually could change in our units. And then putting together some of those pieces, both from what you find in the literature, what the research is telling you, and then what you're observing. Because then when you take your interest, what you've learned, and these observations, something that you've counted and measured of every time I turn on the bright lights, this baby desats, or every time it's noisy, because there's an admission next door to this baby, I feel I'm having to do more containment issues in order to calm this baby down. And then being able to take those observations to your unit to say, can we do something that makes this better? Because here's the evidence. And so I think that's where it starts, where you might not have a team, but you can do a few things in order to help move what your passion is in order to improve work forward.
Sarah, for the next step, how did you bring this question into practice? So what is your project all about? How did it evolve?
Yeah, so our project is, we are trying to standardize care for our small babies. So we classified that as any baby that is less than or equal to 32 weeks and 6/7 weeks corrected gestational age. Our big goals are to be developmental, neuroprotective, and family-centered care. So we were seeing that there just wasn't standardization in how we were providing care for our babies. There wasn't standardization of what kind of lights we were using, whether the door was open or closed, since we have individual private rooms. And another thing that we were seeing is that are there more than one person providing care? Is there not? So we saw a lot of areas of improvement that we could bring about. And so we are thankful that we are using the Vermont Oxford Network, and we are part of that as my hospital. So they are actually doing an initiative called All Cares Bring Care. And that provided us with so many resources as we were able to go be a part of the Vaughan and look on their website and see all of these other hospitals and what sort of improvements that they made. So we got to see posters and projects, and that really helped us when we were going to do our like key diagram of what processes we want to improve, what sort of quality, what outcomes are we looking at. And it also helped us because they have so much research and so much literature on there that when it came to doing a lit review in order to bring to our management to be like, this is why we need to do this project, of like, we can show you that there is plenty of evidence out there in order to help these small babies and in order to bring about change. That literature review and having access to the Vermont Oxford Network was so beneficial. I would say most of my resources and most of my literature that I found was on the Vermont Oxford Network site.
For those of you who have not previously been involved or connected with two organizations that are aimed at collecting data and improving care in NICUs, the Vermont Oxford Network is one organization that Sarah's mentioned. It's a voluntary nonprofit collaboration of healthcare providers and professionals that work together as interdisciplinary communities to change the landscape of neonatal care. Their goal is to improve quality, safety, and value for newborn infants and their families, and they work through a coordinated program of data-driven quality improvement education and research. Vaughan collects data from over 1,200 centers and NICUs worldwide, and so has comparative data on what's happening across the world, but most of those centers are in the U.S. And so then being able to use that data to then inform and have units compare in order to work on improvement. And so, as Sarah mentioned, they currently have a collaborative called All Care is Brain Care, really truly looking at how to protect the infant brain and then how to support and develop the brain from prematurity into the infant that is growing. And so that framework and some of that background work that is necessary in order to start a quality improvement or evidence-based practice project starts by having a literature review, by having a framework in quality improvement that we call a key driver diagram that helps us really organize what we're going to do and the changes that we're going to make. Another organization that does similar work that a lot of our NICUs are involved with is the Children's Hospital Neonatal Consortium. And this group has a lot more of our surgical and our children's hospitals that take care of populations of infants beyond the traditional premature infant that is in the NICU. But they also have ongoing quality improvement work and focus groups in order to work on improvement, incorporating evidence-based practice, and also doing research in our units. And so I encourage each and every one of you to connect with the teams at your unit that are involved in these groups, because they can provide structure and resources for you as you build your own knowledge and your interest in being involved in project work, improvement, and understanding the care that we provide in our NICU. The current project for the Children's Hospital Neonatal Consortium is called Project Home, and is focused on making sure that human milk is provided for infants in NICUs. And so their quality improvement work is really truly focused on making sure that all of the supports and processes, structures that are evidence-based are available in NICUs in order to support those families who choose to provide human milk for their infants.
Sarah, to continue your journey with your QI initiative, what were the next steps that you did after you brought all the data and all the information to your stakeholders?
So after we brought all of our information to our stakeholders, we started brainstorming. What are things that we could do based off of the literature that we have found and based off of other hospitals and their successes? What can we do to improve the care of our small babies? So we started with a fishbone diagram, basically writing down what's the state of the unit and what are things that we wish that we could do or changes. And then we, from there, put them into the categories of neuroprotection, developmental protection and like making sure that they're developmentally appropriate and family-centered care. And from there, then we're like, okay, now that we have these organized into 3 groups, what sort of interventions can we do to get these processes distributed throughout the unit, and how can we make sure that they are actually going to be improving the quality of care that these babies are receiving? So then we started writing down our cycles, and this is when the PDSA cycles came into play, of realizing different phases of the project and different, like, what are we going to tackle first? How are we going to order this so that it's the most cohesive for the unit, and so that we're not trying to throw out 10 different changes at once, because then that's not going to allow us to actually be able to see if anything's being successful. So we're making sure that we're only putting out 1 or 2 interventions at a time, so that we can really target in and be like, is this successful? Is this improving the quality of care that these babies are receiving? Or do we need to go back and re-look at some things? And I feel like with everything, any project that goes on anywhere, you have pivot points of, you were intending to do this, and then you realize, that might not work for my unit, or actually, I found something that's more of a problem, or like something that'll just like fit better. And so it's been a lot of like going to having meetings with our stakeholders and our mentors and being like, here's what we're trying to do, but we came up with this problem or this barrier, and this is how we found to fix it. And it's actually kind of taking us in a little bit different of a direction. So that has definitely been a little bit of a journey there, but I think that that's normal for any project. So if I don't want anybody to get discouraged if they're like, hey, I'm finding that I'm having, like, this is what I initially planned it to be, but now I'm finding that I have to take a little bit of a right turn. And I think that's normal, and that's great. And I almost feel like that's where some of the best interventions are coming at, is because it's all in the learning process of doing the project.
And learning how to be fluid and pivot when you need to.
I feel like if you go in super rigid, you're not going to get what you want out of it. You have to be willing to just like let it flow, find where the project's taking you, and really see where's the biggest need and how am I fixing that. That might not be what you initially thought, but you are going to be making some improvements. It's just might not be where you started.
One of the great things about quality improvement and evidence-based practice, what Sarah just described, tells us a little bit of some of the steps that are really helpful when you adopt and you put your project into a framework and use the methodologies of quality improvement, process improvement, or evidence-based practice. And so what she just mentioned, the fishbone diagram, and so that's really helpful in understanding what is happening in your unit. The next step, as she described it, is our ideal state is that we want this process to go X, Y, and Z. And so really describing, what that ideal state is, and then going back and observing in multiple different scenarios, how is it actually going? And then being able to see that it's not just one way that it goes different than the ideal state, but under different circumstances, there's a few different ways. And then what you want to be able to do, like Sarah was saying, to get to that ideal state is in your unit, what are those areas where you need to take right and left turns, or where you see right and left turns happening, that you need to either use or modify your plan to get to that ideal state. And that's a really important step in developing and working through your project, is constantly evaluating what is current state and what is our ideal state, and how do we make the connections in order to get from current state to ideal state, in order to achieve those improvement processes and improved outcomes for our infants and families.
Sarah, do you want to talk about any other barriers or challenges?
Yeah, so I would definitely say that there are going to be barriers to any project. And some of the ones that I encountered, or things that were like more surprising to me, were it's going to take longer than you initially think to get any sort of change going in the unit. Like, I was like, oh, this one thing, I will have this done within a month. It'll all be approved. It takes way longer than you think. So that at first was almost a little discouraging, because I'm like, I don't feel like I'm making progress. Like, I'm doing all of this work and I don't see any progress happening. But then I'm realizing, I am trying to change something that can impact lives. So like that needs to be, I don't want to be able to just go in and do it and have it be a change that can happen right away. Like there are a lot of people that are very interested in this and a lot of people that have opinions, and it's very important to get all of those. So yes, it feels frustrating at times that it's going slow, but that's almost a positive of like, we are making sure that this is being done correctly and in the right way to best impact our patients. So that was definitely a barrier that I found. Or then I also found that I was getting too much data and I'm like, I have too much now, I'm overwhelmed by it. How do I make this more concise and like filter it down? And then I had to learn new technology. I've never used really Excel in my life, and now I'm trying to figure out how to make formulas and write all these things. So there's a lot of things that are going to come up that you're like, I never thought I'd be doing this in my nursing career, but you just find people that know what they're doing and how to help you, and it definitely can be challenging, and it'll grow you as a nurse, and it'll stretch your way of thinking to now I see nursing and our interventions and what I'm doing at the bedside in a whole different way.
Seeing somebody doing this project, right, your coworkers, and seeing how successful you are really sparks people's engagement too, and say, I can do that too. So you're actually taking on a leadership role because, the hopes is some other nurse is going to come to you with a question and say, hey, can you mentor me? And because I want to fix this problem now. So I feel like once a project gets rolling on the unit, it's really contagious.
Oh, yeah.
And people get that research bug, because how rewarding is it to see your work come to life and see all of these amazing positive outcomes?
Yeah, and I precept a lot of new grads, and so it just comes up in conversation when I'm precepting, and they're all like, wait, this is so cool. You can do this at like not having like 20 years of experience. And so then I'm like, yeah, so like as you're going, think about things, and if there's ever something that you get really passionate about and want to make a change with, you can do it. It's just then you find your support system and you roll with it.
Exactly. And you can do it on any shift, whether you're day shift, night shift, whether you have 1 year experience or more than 20. All it takes is an idea and the enthusiasm to take it further. What are you most proud of with your success?
Ooh, that's a really good question. I think the thing that I'm most proud of is just how open my unit has been to accepting these changes, and to see how excited people are getting when I bring up like, hey, we're trying to standardize the care for small babies to really like give them the best like outlooks on life, and to be able to give them the best chances to go home on like low flow nasal cannula or room air and taking full bottles, and just seeing how excited everybody is, and seeing that people actually are like really wanting to take this seriously and help, and having people come up to me and be like, what can I do? Or like, hey, am I doing this correctly? Like that is just such a proud moment of being like, wow, what I'm doing actually matters and people actually care, and it's not just for nothing. I think that's where I get the most pride and joy.
So for both of you, what do you think holds many bedside nurses or APRNs back from getting involved in research, QI, evidence-based practice? What do you think we can do to overcome these barriers, right? So, of course, everybody will listen to this podcast and see Sarah's amazing work that she did and Elizabeth's mentorship and take that to their unit. But what other things can we do to overcome barriers?
So I think there's a couple levels of barriers. One, I think sometimes we get stuck in our own place. And so whether that's we feel like we don't have the experience or we work night shift. And so I hope that some of those barriers that are internally perceived, we can be broken down as we think about this. And for me at the bedside, when I was a new nurse too, I didn't know how to get started. And so I think that's one of the biggest barriers. But yet my interest in getting involved has to start from within me and asking those questions. And so whether it's to the nurse sitting next to me, whether it's to a physician, a nurse practitioner, even a respiratory therapist, or one of the physicians or nursing leadership, in saying, like, I would love to be involved in something. There are going to be times, I think, that where what your particular interest is might not be something that is supported in the unit, and to not be discouraged by that specific topic. So Sarah was fortunate in order to be able to like connect with something that she was really passionate about. But sometimes the barrier can be broken down, and your own momentum can be accelerated by saying, you know what, I just want to learn about the process and how to get involved. And so even though my interest is in developmental care, but there's a project on pain, I'm going to join in and say that I, as a bedside nurse or a nurse practitioner, would like to get involved. And so just taking that first step in order to like learn how do things happen in your unit, because then once you're involved, then you can see that some of those barriers are broke down, and you can see the process to then like be able to work on your idea being the next project that your unit might take on.
Yeah, I agree. Going off of that from like the bedside nursing perspective, like Elizabeth was saying, you can work any shift. It doesn't have to be night shift. You can have any level of experience. But also, I think it's just really important for bedside nurses to remember, like, you don't have to have a master's or you don't have to have a doctorate to be able to do this, because you will have people that you work with that have gone through this. So you don't have to be thinking, like, I have to go obtain my master's before I can even think about doing this. You just find somebody that has it and you use them as a mentor and let them lead you to it. And then if you still are like, hey, I really want a master's, go get your master's, but it's not a requirement.
When we think about research, quality improvement, and evidence-based practice, a lot of times we hear the end product, a nicely put together project that really seems like unattainable from whatever our position in the unit is. And so I don't want that to be a barrier for anybody, but know that like improvement work starts with the goal of doing one small piece at a time. And so like Sarah said, sometimes it can take a long time to get to what the end goal is. One of the terms that we use in some of the quality improvement work that I do is, what can I achieve by next Tuesday? Because the ultimate goal of achieving that big outcome and being able to have data that really says, like, we did this amazing thing in our unit, really does seem far out, and sometimes we can't even identify when that end might be. But we can do something by next Tuesday or Wednesday, whatever it is. And so I really think about small pieces of a project. And so if it's me personally being interested, I can look up an article, or I can connect with the librarian at the library or in my institution to help me understand what the literature says. Those are things that I can do in a short amount of time. Or I can set up a meeting to ask my leadership, is there anybody working on this project or this problem? So those are all small steps. So really, truly, the PDSA cycle within quality improvement really focuses on small tests of change. And I really encourage everybody that in order to get to the end of any of these projects, whether it be research, quality improvement, or evidence-based project, starts with small steps. Just like when we buy a Lego set for our niece, our nephew, our son, our daughter, or for ourselves, they outline really, really small steps of a lot of times a very complex kit, and we do one step at a time. And that's how quality improvement, evidence-based practice, and the outcomes we want to see happen in our units are achieved, is one small step at a time.
Well, thank you both for joining us today and inspiring us to become more involved in research and realize the profound impact it has on our babies. So thank you. Make sure you never miss an episode of NANcast by subscribing now. This podcast is made possible by listeners like you. Thanks for your support and letting us into your ears. Have a great day.